Oh, okay. Welcome, everyone. I would like to introduce our current speaker, and that's Dr. Davide Piaggio, who is presenting Frugal Innovation for Low Resource Settings. I'm looking forward to this talk by Dr. Piaggio. He's received his Bachelor of Science and Master's of Science in Biomedical Engineering, as well as a PhD in biomedical engineering, with his focus on medical devices regulations within low resource settings. And currently, he's an assistant professor at the University of Warwick and co director of applied biomedical signal processing and intelligent e-health lab, and is involved in many teaching and research related jobs. His main areas of expertise, in which he provides numerous expertise on steering committees, are medical device design, regulatory affairs, CAD design, 3D printing, signal processing, and app design, to name a few. He's also co authored and authored many papers, and his long list of research interests, of which there are many, just to give you a snapshot, of course, is medical device design, management, assessment, and regulations, frugal engineering, M health, addictive additive manufacture, and IPC, ethics, and preparedness and governance. So please welcome Dr. Piaggio. Take it over.
Thank you, Barbara, and thank you everyone that is gonna follow this lesson. And thank you, Paul, for inviting me as well. So, as Barbara said, today we're gonna delve into the world of frugal innovation, which is what I've been working on for the past 7 years. I did my PhD on that, and then continue with the postdoc, and now I'm assistant professor. Just very quickly showing what my lab looks like. There are two directors, me and Professor Leandro Pecchia. We have a couple of postdocs and then 7 PhD students at different levels. The thing to notice in this slide is that we are a multidisciplinary team, so we're not all biomedical engineers. We also have computer scientists, mechanical engineers, medical doctors, and perhaps the most peculiar one in this team is Alessia, who is a philosopher with extensive expertise in bioethics, and we have been doing also some works in these directions. There are some slides on this later on. I think that Barbara did a great job in introducing me. This is just showing what she said about me. If you are interested to know more, you can scan the QR code, but you can find me probably by Googling my name, and Warwick University I should come up as well. Okay, the lab, this is the last slide about the lab. So the lab doesn't only do medical device design for low resource settings. We also work in the aspects of digital health, for example, healthy aging. One of the biggest projects that we have been coordinating and working on is the Gatekeeper project, which was an Horizon 2020 project worth 20 million euro in total. Which was looking at the development of this AI-enabled platform for the healthy aging. So it was a platform for enhancing the clinical decision support for doctors that were looking after patients, and a platform that could put into greater contact healthcare providers and citizens. The learning outcomes of these seminars are understanding what frugal innovation means, why is it important, what are the differences between low and middle income countries versus the wording low resource settings, how can we analyze the context of low resource settings, and how can we use that information to then design medical devices that are more resilient and adaptable to the specific context of use. These has all started with, aligning with the United Nations Sustainable Development Goals, which are 17. In particular, we are aligning with the third one, which is on good health and well-being. It has different targets, which can be found in the on the website of the United Nations Sustainable Development Goals. The results of the slides that you will see in today's lecture are coming from 8 field studies that were performed in 2 years. This is before COVID. I must say that due to COVID, these studies have stopped, but we are trying to organize few more now that COVID, we can say that is in the past. But we have been performing 8 field studies, including in countries such as Benin, Ethiopia, Uganda, and so on. What most people and researchers have been focusing on so far is the relation between how medical devices relate with the people. So, for example, the healthcare staff or the patient. Much less research has been done towards the external world. How does the medical device interact with the environment that surrounds it? And we will see today that this is an important element that cannot be underestimated. Of course, it's important to have an interdisciplinary approach. As with all complex problems, we need to have interdisciplinarity in order to overcome the complex challenges. So we focused on different aspects of medical devices. Now, in this session, I don't know if you're used to this kind of live survey. In this session, I will be interacting with you, asking a couple of questions to just keep you awake, let's say. This is something I do in my class with the students. So if you would like to take part, you just need to scan this with your phone, or just go on vivox.app and just put that ID code in. I will just give you a couple of seconds to do this, and then I will continue. I think there will be about 3-4 questions throughout today's presentation. And in the interest of time, I will not wait for too long for your answers so that we can cover all the slides. Well, all the slides is impossible because it's a lot of slides that I have today, but the main contents. Okay, I think I can proceed with the next slide. And in fact, the next slide shows a question. Press delete to leave me 1 second. Okay. Now I should have opened. So in your own devices, you should see question. I see one person connected. Thank you for connecting. Whoever. Can you still hear me? Because it said the internet. I hope so. Sorry. Well, maybe this is not really working, but can you still hear me? Can you just confirm this? Hello?
Sorry, yes.
I do see it.
Okay,
Yes.
okay. Just because it told
In your
me the
opinion?
internet disconnected.
Okay. Yep. No, it's
Okay,
clear.
okay. It's okay. Thank you. So I think I will skip these questions because they are not really working well with the system, but doesn't matter because I can comment them in this next slide, which is this one. So these are estimates from the WHO. They are not very recent. So in fact, we are trying to work in now to try and update these numbers. Most likely, these numbers are lower in this moment in time, but the closest estimate that we have is this one. So in sub-Saharan Africa, which is made up by mainly low and middle income countries, up to 80% of the available medical devices come from donations, and up to 70% of these donated devices are not functional or broken, and there are different reasons, which we will see. These are a few pictures I took from my field studies. I think the first one is what we call graveyard of medical devices. Of course, there are not only medical devices, but you can probably see chairs in there, but I guarantee you that there are also abandoned medical devices, which is within the premises of a hospital, in the inner yard of a hospital, in the city center of Kampala, Uganda. This is probably something that you would not see in a hospital of high-income country. What happens is that when devices stop working, they get abandoned either like this or in the environment. So they become also, they can potentially be a burden for the environment. The second picture is a surgical bed, of course, this means not working anymore, which was abandoned in the halls of another hospital. And the third one is a stretcher that was near the hospital, but still quite in the wild. There were, you can't really see, but here there is a chicken that was just minding his own business in the garden. So this is sort of a picture, sort of images that you would have in front of your eyes if you were to visit hospitals in low resource settings in low and middle income countries. This next picture again is a question, so I'm just going to go to the answer to avoid issues. But this is another picture I took within another hospital in Kampala, or maybe the same actually, I don't remember. This was the only ambulance available. We all agree that this is not an ambulance, but it was the only means of transportation that could be used as an ambulance. And not only that, but also it has a flat tire, which means that it was not just not a typical ambulance, but not usable. So this is again something that it starts making us understand what it means to be in a low resource settings. I think in Benin I've seen kids being transported to the hospital using those the motorbike taxis. I don't remember the name of these motorbike taxis that they have. In that way, passed out kids with their mom on their back. I mean, the mom in the back and the driver in the front on a motorbike taxi. So this is again some images that we wouldn't really see, for example, here in the UK or in Italy, to name a few countries. So before going into the first step that we thought it was useful was to understand what was a snapshot of the situation in hospitals in low resource settings of low and middle income countries. We came up with this sort of survey that was made up of two different parts. The first part was a big questionnaire which was asking information about the facility, human resources in terms of, for example, how many medical doctors are there per patient, per how many patients, how many nurses, and so on. Questions about the facility environment in terms of isolation from undue noise, from foul odors, and other types of these questions, and questions about medical equipment, so the availability of essential medical equipment. This was done in collaboration with some colleagues that are based in the Centro Piaggio, which is a part of the University of Pisa in Italy. And then we also performed some measurements on actually medical devices that were being used in the hospital. We used this device, which is an electrical safety analyzer, which is used to understand whether the devices that are being used are safe to be used, whether they're protective earth, for example, or insulation, or leakage currents are within standard values. We did this in 3 hospitals in Uganda, 3 in Benin. Now there was one of the PhD students I'm following, who is from Ethiopia, was able to continue this. So there is actually continuation of this work, which has recently been published, but the initial publication, you can see it below. At the end of the slides, you will see that there is one list of all the publications that are basically mentioned in these slides. Well, how did we develop the questionnaire? We started with a focus group with experts, for example, in biomedical engineering, clinical engineering, since we're speaking about hospital facilities. Of course, starting from literature, we had a draft of the questionnaire. We had some validation of the questionnaire via mock interviews and focus groups, where we really wanted to make sure that we were capturing all the elements that we wanted to capture, and also that we were formulating the questions in a easy to understand and correct way. Then we used this questionnaire to as the basis of semi-structured interviews, and we collected also the data with the electrical safety data, and we performed data analysis. These are some of the results. So in this table, you can see primary medical devices, essential medical devices or services, because we can see also ambulance, for example. Wherever you see red, it means that there were 0 to very few of these devices available. And what you can see is that in all hospitals, very complex devices such as colonoscope, mammograph, CT scanner, but also X-ray machine, ambulance, defibrillator were all basically not available, or there was only one. One other thing to notice is that not only this, but also oxygen systems and ventilators were quite rare to be found. This is a survey that was done right before COVID. It was, I think, November 2019 or December 2019. So imagine this was the starting point when COVID came, when high-income countries already faced a lot of issues with the scarcity of devices that were essential to cure people, to avoid people with COVID, with serious COVID to die. These countries were starting from an even worse situation. These are some pictures of us. This is me and Busola. Busola was a PhD student like me. Now she's a postdoc in a rural hospital in Benin. This is the one to the right is a surgical theater in one hospital in Benin. What you can find here is this picture is here because it shows that there is a window, and by requirement in a hospital in at least in the UK and Italy, there is a requirement to have air filtration on 99.97% in a surgical theater. So this is, of course, this requirement was not followed here, and this has some repercussions on the medical devices. For example, those that are that could be sensitive to high humidity and dust. In some of these locations, the amount of dust is higher than other locations. These are the results of the survey. So we were asking about how many power outages has the hospital had in the past month. We can see that there were many in in 3 hospitals, more than 10 in a month, means 1 every 3 days there is a power outage. And we were asking also what was the perceived quality of and access to electricity. You can see that in this case, people were replying in different ways. For some, this was poor. For some, this was good. For some, this was acceptable. We were also recording the type of electrical safety systems that the hospital had. Normally, in a hospital, you would have earth grounding, so like you have in every home, which is the pin in the UK is the middle pin of the socket. This is the first line of protection, but for hospital, this is not enough. In fact, in hospitals, you also have equipotential nodes. And in some areas, you are required to have also insulation transformers. In this case, you can see that not all of these systems were present. One issue that we also highlighted is that the incompatibility between the plugs of the donated medical devices and the local sockets. You can see that in one case, in this hospital in Benin, we had 0% compatibility. This means that the healthcare workers that need to use these devices will recur to using adapters, which is sometimes not really not a very good solution because it can hinder the safety of the device. And we can see, I think we can see in a few slides what this means. These are the results of the survey in terms of insulation. We can see that all these hospitals were quite poorly insulated from noise, smoke, dust, foul odors. This is something which are all important features to have for a place where people are there to, recover from illness. So again, this is something that characterizes hospitals in low-resource settings. These are the results of the electrical safety measurements. I won't bore you too much with this information, but what normally is measured from clinical engineers is the protective earth of the device, the insulation, and the leakage currents, which have to be within certain thresholds that are set out by standards, international standards. So in this case, we tested the devices that were available and were not, we were given the opportunity to test. And what we could see is that while all the insulation leakage currents were okay, in terms of protective earth, some of these devices, these ones in red, were out of the standard, which means that potentially there could be a risk for the user to use these devices. These are some pictures taken of some of the power plants in the hospitals. And what you can notice, this is the adapters usage. What we were measuring here was the voltage on the ground pin, which is what I mentioned before, the grounding, which is this middle pin here, which normally should be 0. If we lived in an ideal world, we don't live in an ideal world. So even if I was to measure it in my office, would be a few volts, 3, 4, 5 volts. But here we're reading 84, 52, 94, 107. This voltage, this means that the system is not working properly, and or because there is a use of adapters. This basically hinders the safety, the first safety net of the hospital room or office room, whatever room, because if the voltage is too high, this system won't work. The way this system works is if there is a problem with the insulation in the device and we are exposed to a voltage, the current, rather than flowing through us, will flow through the least resistant path to the ground, which should be potentially this pin. But this is not the case because we have this voltage here. So we also investigated the quality of this electricity. We used a voltage recorder from Fluke, I think, and we recorded, I don't know for how long, the voltage events in the sockets in the hospital. All these dots in the middle that you see here are events. So what it means, events? It means that they can either be sags or swells. So when the voltage went over a certain amount or below a certain amount, it was recorded. These events do not only have the voltage as variable, but also the duration. And depending on the combination of the two, they can be potentially dangerous for the equipment. And what we found is that basically referring to these two curves that come out of the standards, the green one is for medical devices. So this one gives us only the lower limit, a lower threshold, while the orange one is for IT equipment like computers. But we all agree that nowadays medical devices are, looking like are more and more advanced and looking like IT equipment. So potentially we had over 500 measurements out of threshold. So this could be one of the reasons why many devices that maybe arrive functional with a donation, they get broken quite easily. And then they get abandoned because there are not spare parts that to fix them, or maybe there is not expertise available in the hospital to fix them. So what we did was performing also a SWOT analysis, which is weaknesses, strengths, opportunities, and threats. This is on the left, you see the general idea. On the right, you will see an example applied to Benin, because it was the first country that I visited. But the elements on the left are applicable to many low and middle income countries, at least for sure in sub-Saharan Africa, but I think in general. So among the weaknesses, we have, of course, an extremely limited resource country. Benin, this maybe has changed, but a few years ago it was among the 30 poorest country in the world. There is a very little number of medical doctors. In Benin, there is 1.5 per 10,000 population. As a reference, in UK, we have 28, which is 20 times higher. In Italy, I think even more, maybe 40, and yet we still complain that there are not enough doctors. Poor infrastructures, electrification rate, we sort of saw that in the previous slides, but these are official data. In Benin, only 38% of the population is covered by electricity, and the quality of this electricity is quite low, 1.7 out of 7. 7 means perfect electricity. The distribution of resources is heterogeneous, but this is true in every country. Also in high-income countries, the capital region will always have more resources compared to more remote areas. But still, among all these weaknesses, there are also strengths, because there is a very big diffusion of mobile phones. For example, in Benin, 82% of the population, again, this statistic is from a few years ago, so maybe I think now it will be maybe even higher. 82% of the population owns a smartphone or a mobile phone. This is quite similar to countries that are high income. For example, the statistic for Canada, I think, is again in the 80s. In Italy, we have more. We exceed 100. I think the data is 130%, which means that some people own more than one smartphone. But what does it mean? It means that we can leverage digital technology, especially mHealth, so the development of apps that can be used on the phone for example, screening of certain conditions and so on. The population is very young, much more than European population. Over 65% of the population of Benin is under 25 years old. What does it mean? That they are easy learners, accustomed to technology. There is not much the risk as there is sometimes in Europe, where it can be that there is some inertia in the elderly in uptaking these technologies, because these people, have been young people were born when these technologies already existed, basically. Resilient healthcare operators. This is another thing that we observed. What does it mean? It means that they are flexible and adaptable, because they have so little resources. You will see perhaps a nurse conducting certain types of surgery in the middle of in remote areas, in remote hospitals in remote areas of Benin, because there is no other chance, and if the nurse doesn't intervene, the patient may die. So this wouldn't probably happen, doesn't happen in I don't know, UK or Italy, where because well, we are luckier, we have more resources, but a nurse is not put in this situation. Opportunities, the medical device market is growing. Africa is not the leader in this in the share of this market. I don't have a slide on that. The leaders are the US with I think 48%, followed by Europe with maybe 28%. And then Japan and China, but still the medical device market is growing, and the biomedical engineering school, so education, is also growing in many African countries. A good coverage of wireless telecommunication. Also, this is true. I was quite surprised when, with my mobile data, I had very good reception. Also, when I was visiting a forest in the middle of Uganda. When I'm at home in Italy, if I go to the village in the hills, sometimes I do not have service. So to me, this was very impressive. I wasn't expecting that. Of course, there are threats, because the solutions that one could come up with in terms of resilient medical devices could become permanent, but we may risk to forget about the bigger picture, which is also about more inclusive and universal medical device regulations and standards that take into account different settings. And also the fact that an empowered operator, so a medical a nurse or a lay user with an app on the phone that allows them to screen, to do the job that a medical doctor would do, are not yet, better than medical doctors. We will see what happens with AI, but at this moment in time, the medical the doctor is the point of reference. This is just a table that compares, gives you an opportunity to compare what it means to be a low and middle income countries versus an example of high income countries. So we have Uganda, Benin, Italy. We have already mentioned all these aspects, the physician density, quality of electricity, how much electrification rate, mobile phone subscriptions. We also mentioned this. And this brings me to the regulations that I mentioned 1 second ago. The current standards and medical device regulations, this question is provocative, are not really universal, because the way it works is that, how does it work? So we have international standards upon which minimum requirements are set. These minimum requirements, depending on the country where we are, could be mandatory by law. In Italy, they are mandatory by law. In the UK, they are only strong recommendations. They are called health building notes. They are the ones, for example, that say that there should be air filtration at 99.97% in surgical theaters. They can be of three kinds: structural, technological, and organizational. So, for example, we have organizational in terms of how many specialized doctors do I need for a specific department? What is the total number of the personnel that I need for this department? Structural, for example, how much space do I need to have for bed per patient? How many toilets? How many separate toilets? Technological, what's the minimum technological equipment that is needed for, I don't know, an imaging ward? What's the minimum emergency equipment? These are all there to make sure that the safety of people that are being taken care of, and the comfort are taken into account. When we start going into locations where we are in low resource settings, we cannot really find. Sometimes these requirements are too strict to be followed because of the lack of resources of the setting. So what happens is that medical devices that are designed and developed with these conditions, this scenario in mind, the scenario set by the standard, so an ideal world, when placed in a setting where these requirements sometimes are not really respected, fail to really work properly, or can be even dangerous to be used. And so this is something that also needs to be taken into account. So this was, let's say, the first part where we looked at how we could assess the challenges of the healthcare location. The second bit is what are the criteria then that we need to take into account when developing and designing medical devices that are resilient to the challenges set by low resource settings. So this scheme is very similar to the previous one, so I'm not going in too much detail, but we started also from this. This is a very nice publication, WHO Compendium on Innovative Health Technologies, which is a series that is released I don't know if every year, but there are a couple out now. And collecting information from our field study and from brainstorming, we came up with a set of criteria that then we, thanks to focus group, divided into different domains. We based our questionnaire on these domains and criteria that we found. We had, we administered the questionnaire, and we could come up with the weighting of the criteria. So actually, there are two things that we did. We ran a Delphi survey, which is used to raise consensus on a certain matter. In this case, we wanted to raise consensus on a set of criteria that should be used for designing medical devices resilient to low resource settings. We have a panel. The panel description is in the next slides. And normally you have rounds of consultation until you reach consensus, which you need to define what it means to you. I mean, consensus, how is it defined? Also, you can look whether the panel of people would suggest new criteria, and whether if they suggest new criteria, there is consensus also on that. As I said, you would need to define what consensus means. There are different ways. One way is to look at the interquartile range, so how spread are the answers. We had different levels, so if the interquartile range was 0, it meant full consensus means that everyone scored, let's say, on criteria X gave a 5. I forgot to mention the question that we were asking were of the Likert scale type. So how important do you think that user friendliness is as a criterion for designing medical devices for low resource settings? 1, not very important. 5, very important. And then we measure consensus in this way I was mentioning. We also looked at reliability, which is a very important value for these type of questionnaires, where, because we divided the criteria into domains, reliability measures that a certain criteria within that domain is captured by it's measuring whether the criteria within the same domain are capturing the same overarching concept. So are they placed in the right domain? So this is, again, you can do it with these polychoric matrices and ordinal alpha, correlation, and also we calculated the ranking, which was a weighted average, basically, based on the amount of answers that were given, of people that were giving 5, that were giving 4, 3, 2, 1. The panel characteristics were, well, most of them were, half of them were biomedical and clinical engineers. Then we had people working on medical devices and instrumentation, people looking after the hospital maintenance, health technology assessment, and so on. And this is a map of the replies. I don't remember at this moment. This is also described in a paper. So if you're interested, you can read all the details in the paper. but we had a couple of replies. Normally, for Delphi service, you would like to have something between 10 to 50, I think, panel members, and we were in this range. I think we were in the 20, 30s, more or less. The darker, you can see that we had quite a big outreach. We were missing quite a lot of countries. For example, in Asia, we only had, I don't know which this country is, but it doesn't matter. We only had one. The darker the color means the more respondents. So actually, we were quite happy about this because our setting of target setting was actually Sub-Saharan Africa, and this is where most of the respondents were based. This is a question, so I'm gonna just skip it and go to the result, which is this. So this is the framework of criteria that we came up with, divided into different domains. In this slide, they are not ranked. In this next slide, there will be the ranking. What you can see is that we have 1, 2, 3, 4, 5, 6, 7 domains divided into, for example, cost, which does not only mean initial cost, it also means maintenance cost, running costs, which are sometimes bigger than the initial cost. Lifetime, how long is the expected lifetime of the device or the components of the device. Health technology management, how easy is it to install the machine? How frequently does it need to be maintained? How complex is this maintenance? Design, so portability, compactness, how many components does it have? Reusability, are there parts that can be reused? Materials, in terms of robustness and durability. User type is also very important. What is the end user background? Can this device be used only by a medical doctor? Can it be used by also a nurse with training? Can it be how reliant is it on power sources? We saw that the electricity is not really either good quality or very accessible. So are there other things that can be used? Are they battery based? Can it be used with, solar energy, this kind of solutions? How resilient is it to dust environment? How resilient is it to high humidity or high temperature environments? So these are all the criteria that we came up with. And this is the resulting ranking that we had. So what you can see in this wheel is that from the top right, going clockwise, they are from the most to the least important, although a little disclaimer is that they were all quite close. So they were all ranked as very important or important. So the difference between these ranking is minimal, but still we're showing it to show what was the result. So we had cost as the first, lifetime, health technology management, design, user type, materials, and reliance on external factors, which we think this is sort of the snapshot of what people believed. Because if you were to go to someone, general lay audience, and ask, okay, I need to design a medical device for low resource settings, what do you think is the most important thing that you have to look at? They will say it has to be low cost. I would bet on it. So this is what you see here. We have cost as the first one, but we also think that other things cannot really be underestimated, because even if you're able to purchase and afford the maintenance cost of the device, then if the other domain are not really looked at, the device, when placed in a setting with these challenges, will fail. So also the other criteria are very important to be taken into consideration. So what this basically means, frugal engineering. So what does it mean, frugal? Frugal is a word that comes from if you were to look it up in the dictionary, you would find simple and plain and costing little. Is a word that comes from the ancient times. Already the Romans in the Latin, in using Latin, where comes from the Latin word frux, which means fruit. Frugal used to mean someone that lives by their own agricultural produce. Frugal engineering was coined by this Carlos Ghosn, that now I don't remember. I think he was the CEO of some car company. That defined it as achieving more with fewer resources. So it means a sustainable approach to engineering. So the three pillars of frugal engineering, which are very well defined in a paper, not one of my papers, but the papers I had found online, are cost reduction. So we need to reduce the cost, not only the initial cost, but also the cost of ownership. Core functionality, which means that we need to reduce the complexity and respond efficiently to the essential need of the context, and optimize the performance, so in terms of durability and accuracy, taking specifically into account the requirements of the context and the users of a specific location. Now, these car horns in India in the example is really written in the paper, but I think it gives you it gives you an idea of what it means to optimize performance. I don't know if some of you is from India, or if some of you has ever been to India, but if you drive in India, you will hear constant beeping sound of people activating their car horns. This is not something that you would find in the UK, for example. What does it mean? It means that those car horns need to be more durable because they are used much more frequently. And so optimized performance in this case would mean to design them so that they are able to withstand a much more frequent use without breaking down. The same goes with medical devices. So if there are specific challenges that only take place in these kind of settings, then we need to first of all identify the challenge and then understand how we can optimize the performance in that direction. Two typical examples of frugal innovation are the Jaipur foot, which is a prosthetic leg made almost entirely from rubber from the irrigation piping. The other one is a more recent frugal innovation, which was released during the COVID pandemic, where Thermoplan released this lung ventilator, which was based on 80% of coffee machine components, and this allowed them to produce it at a mass production of 800 per week to 25% of the original cost of a ventilator. So this is also where frugal innovation, I haven't mentioned so far, but low resource settings are not only a peculiarity of low and middle income countries. Low resource settings can also be found in high income countries, especially, for example, during emergencies such as the COVID-19 pandemic, or in very remote areas. So frugal innovation can also be something useful for high-income countries, because anyways the budget is always limited. The NHS UK has a limited budget, so also in this case frugal innovation can be helpful. Now, in the last, I think I will try to wrap up in 5-6 minutes, so we have a couple of minutes for questions. I will just go quickly through some examples that I've been working on. If you are interested, you can find the related paper at the end of these slides, and these examples, let's say, put together 3D printing, which is something I've been, which is one example of additive manufacturing, ML, so applications for the mobile phone, for the digital health, and artificial intelligence. The first example is a smartphone-based pupillometer. Pupillometer is the pupillometer is a device that is used to understand whether we have a physiological reaction to a flash of light. I'm sure that you have seen in the movies where there are accidents and people go to the ER. the doctor will use normally a flashlight, a pen light, to flash the eye and see whether there is a good reaction. Good reaction means that you have a brisk contraction of the pupil and then a slower redilation. This is one way of checking, for example, whether there is brain trauma. And in this case, we were aligned with this target. I mentioned before that the United Nations goals have target. One of them was, for example, to reduce the number of deaths coming and injuries coming from road traffic accidents by 2020. I don't know. Now we are in 2025. I don't know if we met as a humanity this goal or not. I have to check. In any case, what we decided to do is to try and see whether we could use the flashlight in a smartphone, the flash in a smartphone, to perform the same, and then try to see and compare it with a commercial infrared pupillometer. Because I mentioned there is the pen light, which is very affordable. This is what you see in the movies. But requires a specialized doctor, and even there are studies showing that different specialized doctors will interpret the same reactions in different ways. So there is a need for standardization. This other solution is infrared based, is much more expensive. So we said, why cannot we use a smartphone, which is available, quite widely available, and just have an app that does that? So this is the initial work that we did in that aspect. This is exactly the same slide, just in a different format of the SWOT. So I'm not going to go into the detail, but I'm just going to say that these were our requirements. And especially we wanted something that had no accessory, so that, if the accessory breaks down, then what happens? If you are in a low resource settings, maybe it's not so easy to replace it. That required little maintenance, that was using visible light, because the smartphone doesn't have infrared. And this has really driven the specifications of our algorithm, because, for example, the fact that we were using visible light with a visible camera, when there was the flash, we had some artifacts in the signal that we had to take into account. And also the fact that there is not like any accessories and the smartphone is handheld. There could be variable distance because of the hand movement between the eye and the hand, and this could change the perceived size. And so in order to overcome that, we basically look at the ratio between pupil and iris, because while only the pupil will react to light, both of them will change their size depending on how far the camera is. This is when we were still doing separate flashing from one phone and retrieving the image from another phone. We then created this MATLAB code that was looking at finding both the pupil and the iris using, for example, circular half transform. This is the light blue signal is what we were getting from a raw video. So you can see that where the flash was, there was a spike in the intensity. And this is because we were using, visible light camera. This is not would not be seen by an infrared camera. So what we did here in this signal in particular, we just did a linear interpolation, but then we did use other kinds of interpolation. Also, when blinks were there, there were some artifacts. This is just a video of you can see when there is the blink, the circle doesn't really circle the pupil, but this is that's why we had to do all this software pre-processing to bypass that. Okay, these I can skip. And then one of the most important bits is that we validated it against an infrared pupillometer. So what we did, we took videos that were acquired from a benchmark, a CE-marked pupillometer, and we run this video on our software. I mean, we run our software on this video and we also took manual measurements. The blue dots are our manual measurements. Manual measurement means that on the, let's say, paint, we were measuring manually how big was the diameter of the pupil. The yellow is the outcome of our MATLAB software. The red is the outcome, the output of the infrared pupillometer. So you can see by eye already that we are quite closer. And this is also visible here in the top bottom right. We were calculating typical variables of pupillometry, like the pupil minimum, the maximum constriction velocity. You can see in all the bold cases that our percentage error was lower. Let me just check the time. Okay. This is just extra information. So when you validate devices, these are Bland-Altman plots. When you have two devices that are measuring devices, you can use Bland-Altman plots to see how much agreement is there between the devices. What we did was, let's check the agreement between the infrared, so the benchmark versus our manual measurements, and between our software and the manual measurements. The closest the red lines, the better it is. And I left, this is unreadable, but I left it on purpose on the same scale so that you can see that we are, in our case, the lines are much closer. I think I will just mention what the other technologies are and then leave for questions. So this one is, we were working also with a podologist in terms of how can we improve the screening for diabetic neuropathies. These are a very big issue everywhere, but especially in low middle income countries, because if they are not, if they can cause mortality or amputations or mortality if, for example, you get a cut in the foot and you don't really feel it because you have this nerve conduction problem. If left untreated, you can lead to an amputation in the best case, or death if the infection goes forward. So I will leave to you, if you're interested, to read what we did in the connected paper. And then the last example is about a 3D printed condom intrauterine balloon tamponade. So this is for postpartum hemorrhage, which is again another big issue in low and middle income countries. I think 25% of maternal mortalities worldwide are due to this condition, which is a loss of more than 500 milliliters of blood right after the hemorrhage. And of course, if you are from a low resource settings, your chance of dying from this is, I think, 20 times higher. So again, we looked at what we could do there. Again, I'm not giving too much detail now because there is no time, but I think this is a good taster that if you're interested, you can go and look for it. This is the compendium. This is the latest one, 2024, which I had the pleasure to be among the reviewers of some of these technologies. I think is a good read if you have never read it. Medical device donations, considerations for solicitations and provision also is a document that I contributed in writing. Again, also that is quite interesting. And this is just a collection of other works that are also important, but now I cannot really speak about, which are about the social acceptance of, in this case, we're about COVID. But one thing I didn't mention is that in terms of also of medical devices, it's important to look at the acceptability of the device and the compatibility with the local culture. These are the references that you can look at your own time if you're interested. And I think this is all from me. I'm happy to take questions.
Excellent. I want to thank you for this excellent presentation. First of all, you really outlined really important concepts, like power outages is very common, and and you're targeting, what I appreciated is you're targeting what they do have, and a lot of it is their phones. So definitely that's the avenue to go or the venue to go is smartphone based, for example, screening tools. And I love that idea. I do have a question for you.
Yeah.
When you are looking at designing and using your, for example, the materials and whatnot for these medical devices, and if these become shared, so in other words, it's being utilized from one patient to another, do you look at ways, for example, how is it disinfected between patients?
Well, yeah, this is. Let me add a disclaimer. None of these devices that I showed are only prototypes. We, of
Right,
course, to bring them to the next level, we would need, further
right,
testing and that. But of course, one aspect is definitely also in terms of how things can be sterilized. Between one patient and another. And in fact, for example, for 3D printed parts, I think that not all kinds of sterilization. Now, I'm not an expert of sterilization, but I don't think that you can apply all types of sterilization methods. But one thing that we were thinking, for example, for the intrauterine balloon tamponade,
yeah,
which is effectively made by a condom that, of course, that wouldn't be reutilized. So you use a new one, which is coming in a sterile pack. While the other bits that are 3D printed, if you wanted, you could, there are protocyclers, are devices that allow you to take print scraps or prints that you don't use anymore, grind them, and then adding just let's say 50% of virgin pellet, you can fuse them into new filaments. So this fusion
right.
happens at very high temperatures. So we think that, of course, this is just. I think were some studies actually. It's not just talks. I think I remember seeing some studies that were seeing after this process if it was enough for uh, removing bacteria and germs. Now I don't
Right.
remember, but I remember I read something like that in my studies. Yeah.
An excellent point too is, and what I really love about the work that you're doing is you're engaging your ethics. And as we know with COVID-19 pandemic, we've come across many, many ethical decisions.
Yeah.
For example, reuse of medical masks or N95 respirators.
Yeah.
And that was even in a country that was rich. And, these were some of the things too that we experienced during our time with the pandemic. But yeah, I'm excited to look at some of your other prototypes. And at this point, can you move the slides to the next?
Sure.
Um, uh, yeah, so Weber training is also the next Weber class is Afro-European teleclass. We look at the cost analysis of hand hygiene improvement strategy in long-term care facilities. And then also the Australian teleclass, which is the impact of sink removal and other water-free interventions in intensive care units on waterborne healthcare associated infections. And looking forward to all those talks and speakers. And again, I want to thank you, Dr. Piaggio, for your enlightening teleclass. Thank you again, and thank you everyone for joining us. And without the next slide, without the teleclass education, we cannot thank our patron sponsors enough. We have Diversity, Virox, and Gamma Healthcare. So thank you everyone for joining us, and goodbye.
Thank you. Thank you.